Great. Well, thank you so much. It truly is an honor to be here, to be the first speaker for the Paul Terasaki lecture. Dr. Terasaki and I go back a long ways back into the 1980s, actually. And at that time, I was interested in statins, interested in cholesterol. And we did a clinical trial in heart transplantation. We randomized 97 heart transplants to either statins or no statins. And we found some very interesting results. We actually found that statins could actually decrease rejection, actually in the innate pathway by knocking out natural killer cell activity. And so we had to prove this. And so I went to Dr. Terasaki and I said, Paul, can you help me out on this? He said, sure. He had just developed the microwell technique. And he said, yes, I can do natural killer cell activity, percent lysis. And sure enough, we found that we had knocked out natural killer cell activity with statins. And it wasn't just related to the amount of cholesterol, it was actually cholesterol independent. But it was Dr. Terasaki who really paved the way for us to find a mechanism by which statins would help our heart transplant recipients. So to this day, I have a lot to owe to Dr. Terasaki in terms of that finding. Well, let me now continue with our study, with our lecture here. And we'll talk about the antibodies and transplantation, 50 years of progress. And here is my disclosure. I will discuss off-label use of rituximab, bortezomib, eculizumab, tocilizumab, and if you can remember all those names, you're better than me. And you see my relationships to disclose as well. And so it's hard to believe that in the beginning, 50 years ago, you see these two very young men, Tom Starzl and Paul Terasaki. Now, at that time, what were they discussing? Well, we can imagine what they were discussing. Were they discussing antibodies or the fourth race at Santa Anita? I don't know. But Paul Terasaki was certainly a driven person to really achieve the highest in quality in his laboratory research. Today, or this year, celebrates the 50th anniversary of this very important publication in the New England Journal of Medicine. And it was entitled, The Significance of Positive Cross-Match Tests in Kidney Transplantation. Dr. Terasaki noted that the cross-match test of the prospective kidney transplant donor's lymphocyte, which is the serum of the prospective recipient, in 225 transplants show that 8 of 195 with negative cross-match failed to function immediately. But in contrast to 24 of 30, 80% with a positive cross-match, and your p-value was highly significant. Immediate failure occurred in significantly higher numbers among patients with a higher risk of having antibodies. And this is hyperacute rejection, in such as multiparous females, patients with, receiving a second transplant. Paul experienced all of that at the very beginning, and little did we know what was happening at that period of time. The effect was not a specific one for more immediate failures occurred among transplants from unrelated than among those with related donors. And you can see the bottom line was that the presence of preformed cytotoxic antibodies against the donor appears to be a strong contraindication for transplantation. So Dr. Terasaki set the tone here that antibodies are something to be dealt with. But even then, there was still consternation and deliberation as to whether or not antibody-mediated rejection even existed, even though with this publication. Well, Dr. Terasaki persisted, and there are many things that he did in terms of innovations with antibodies. He helped to define HLA typing, anti-HLA antibodies, and the consideration for a prospective cross-match prior to kidney transplantation. He developed the microwell lymphocytotoxic test, and we'll talk about that in a little bit, and luminal single antigen beads. Now, what about that microwell test that we talked about? Well, this was the first test back in 1968, a tray that you could use microliters of basically just tiny, tiny samples of serum. And the serum can be tested against 60 different donors to detect antibodies. And in the seminal paper that Dr. Terasaki wrote, basically he defined what hyperacute rejection was all about. again, preformed circulating antibodies. And it's useful in identifying cross-match negative recipients as well. So safely, you could go on to transplantation. And in that seminal paper we just talked about, 80%, 24 of 30 patients with a positive cross-match had that hyperacute rejection. Well, we probably don't see hyperacute rejection very much. How many of you have seen hyperacute rejection? Nobody? Well, very few people. Well, I have. Back in the 1980s, when we started transplantation at UCLA, back in 1984, we really didn't know a lot about these circulating antibodies. And we would check, but basically we didn't have much to check with. And yes, we saw several hyperacute rejections where the heart turned stone cold in the operating room. Well, you might think what's all done with at that point in time, but we persisted. We put patients on ECMO, on extracorporeal membrane oxygenation, the heart-lung machine. We gave them everything. We threw the kitchen sink at these patients, OKT3, Cyanamidrol, plasmapheresis. And the heart started to come back with us. It was pretty amazing. Now, that wasn't the case in every one of these hyperacute rejections, but we could salvage some of these, but by and large, they were not a pretty sight to be seen. We even tried to retransplant some of these patients because we didn't know that there were circulating bad humors that were in the bloodstream. And when we put in the new donor heart, it failed also. It didn't work. And so people tried to do that in terms of heart transplantation, and what we found is that these patients had horrendous outcomes. And in fact, with the guidelines in the ISHLT right now, we don't really transplant patients who are having high levels of acute rejection at this point in time because outcomes are very poor, and we're generally, in general, wasting a new donor heart. Well, let me move on. Because the microwell technique was also helpful in pre-sensitization, basically telling us when patients would be safe for transplantation. And if the tests were 0, basically it was negative against donors and you could proceed with transplantation. Now, in the pre-sensitized stage, you can also have the percent of PRA, basically gives you an idea about percent of positive wells, meaning there's cell lysis against random donors. And so Dr. Terasaki said, well, what about these pre-transplant antibodies? Do they really have any clinical application? So basically, he looked at outcome of kidney transplant patients, and in that same year, 1971, found that if a PRA was greater than 0%, their survival was much less. Well, so Dr. Terasaki was at UCLA at that time. He had done his PhD. And he was hired by UCLA, and he told the UCLA leadership, look, I've got this great idea to start this laboratory about defining what antibodies are, and we could really do well. And UCLA said, nah, I don't think so. Why don't you just take it outside and make your own company? So that's what Dr. Terasaki did. He went out and formed One Lambda. And this is circa 1984. And this is the 7 founding members. Oh my God, where is Ricky? Oh, okay, well, he was a very young guy. You can see that's 35 years. I see all the cameras going up. Uh-oh, you're in trouble. Okay. But nonetheless, it was a great move, a great company that Dr. Terasaki could then move forward and have many more innovations to follow. Well, then in 2003 came the single antigen beads, and again, that revolutionized all of transplantation in terms of really truly finding out what antibodies we were dealing with. Single specificity, basically the latex beads being surrounded by various HLA antigens. And with this, you could use the patient's serum, and if there were antibodies in the serum, they would attach on to these antigen beads. And using laser and fluorescence, these would be tagged by fluorescent tags. Basically, you can see what type of antibody you would have. And then you get down to specificity. And with the specificity, you can not only detect what antibodies were there against what antigens, but also the amount of binding, the binding strength of these antibodies as well. And basically center in on the specificity of the antibody by itself. So there were many advances over the years, and when you look at 1970, there were only 6 HLA-A alleles that were known, only 5 B alleles that were known. move forward to 2013, you can see we've now isolated 30 A's, 66 B's, 21 DRs. And if you do high-resolution typing, we're even better than that at this point in time. So with more accurate typing done by over 100 UNOS laboratories, what are the results? And that's what Dr. Terasaki asked. He said, well, what are the results with all of this? Well, in 1970, you see there's only about a 50% survival if you combine matched and mismatched donors to recipients. So what happened in 2013 with 26,000 matched, 165,000 mismatched, and you had 90% survival? Amazing. So we've really progressed with the idea that we could actually detect these antibodies and maybe do something about them. And we'll talk about that, in a little bit as well. And so Dr. Terasaki asked the question, but this applies only to early results at 1 year. Now, what did he mean by that? He looked at a large registry, multi-center registry, and basically came out with this. He looked at kidney, he looked at heart, he looked at liver. And you can see 1 year survival, at least at 2013, was about almost 90% at that 1 year. But look at this. The survival tapers off quite significantly. By 20 years out, only 15% of the grafts are still around. And if you push that even further, you would see that by 50 years, none of the grafts would be working. Well, be 70, 80 years old, but nonetheless, be pretty old at that point in time. And what about heart transplantation? 20 years, 19% are only around. So something is going on with all of these donor organs. If you look at the time it might be all gone, 34 years, and finally with liver, 29%, grafts still around at 20 years, and by 43 years, all of them would be gone at that point in time. And so Dr. Terasaki basically formulated a plan that he thought that antibody-mediated rejection was truly the cause. In 2004, we had a meeting in heart transplantation, and it was a contentious meeting. Basically, it was a meeting to define whether or not antibody-mediated rejection was true or not, and whether or not we could have a pathology definition of antibody-mediated rejection. I know some of you might have been there at the meeting. Adriana, yes, was there. But it was very contentious. People were yelling. People were shouting. People were saying, I'm going to walk out of this room because we don't believe it. And so, fortunately, level heads persisted, and we were able to say, can you live with this? And we were able to come up with a basically yes, no, plus, minus. There was antibody-mediated rejection, mostly by C4D staining at that point in time. But just to give you an idea that it was contentious, but yet Dr. Terasaki persisted, saying, you know what, I still believe in this, and that truly is the way these grafts actually have a demise. And so he also looked at this large registry, and you can see on this curve here, your no antibody, you have about close to 85% of 4-year survival. Overall, there was in 964 patients, it comes down to about 75% at 4 years. But what happens if you have antibodies? Well, if you have antibodies, you have about a 55% 4-year survival. So again, suggesting that something else was going on, and that if you do have anti-HLA antibodies, again, your survival surely would be curtailed. This occurred also in heart and lung transplantation. And if you look at these curves, very similar to what you had seen previously. Again, and there are many other registries that have shown the same thing in thoracic transplantation. And so where do we go from here? Well, now we have high-resolution HLA typing, molecular mismatching that you heard from Chris Wiebe this morning, immune biomarkers, gene expression, microRNA, mRNA transcripts, a lot of technologies that we have available now to look at antibodies and look at antibody-mediated rejection. And I'll talk a little bit about this as we move further as well. All right, so we know that we've really progressed very well in terms of the detection of these antibodies. Now, clinically, how did we look at that? Well, I talked to you about 2004 when we talked about thoracic antibody-mediated rejection. And in 2004, Steve Takamoto put together this national conference to assess antibody-mediated rejection in solid organ transplantation. And this included not only kidney, but also lung, liver, heart transplantation as well. And I'll show you the next slide how we defined antibody-mediated rejection at that time. And if you look at the very bottom, down here, serologic evidence for anti-HLA or other antibody action that's there. In other words, a non-HLA antibody. And so we mandated that you had to have antibodies in order to call antibody-mediated rejection. Well, it kind of made sense at that time. But we also said you also have to have evidence for clinical graft dysfunction. Now, in heart transplantation, that means you have to have a decreased ejection fraction or hemodynamics that are very poor. And of course, histologic evidence, and we know from our pathology colleagues, Dr. Mengel this morning, presented data in terms of pathology, and also immunopathology, meaning mostly C4D staining, to say the least. Well, let's move forward with that, because as we evolved with antibodies, we also realized that sometimes we don't detect antibodies when we have antibody-mediated rejection. And so we had this consensus conference in April 2010. And in this conference, we met at the right before the International Heart Transplant Societies in Chicago in 2010. 83 pathologists, immunologists, clinicians representing 67 heart transplant programs from North America, Europe, and Asia. And basically what we were able to do is to come up with a pathology definition of antibody-mediated rejection. We called it AMR pathology, AMR 0, 1, 2, 3, which is no rejection, mild rejection, or suspicious for rejection. AMR 2 is pathologic rejection, and 3 is severe. You can see what we have listed there. I don't really need to go into detail. But this is what it actually looked like in terms of the hematoxylin eosin staining, low power, high power. You see macrophages in linear formation here. This is CD68 for macrophages, CD3 meaning T cells, a dearth of T cells, CD34 outlining the endothelial cells, and C4D staining the complement fragments. So if you have all of this on this side, you can say, yeah, that's antibody-mediated rejection. But there is a problem with that, and that is that you don't always see graft dysfunction, and you don't always see antibodies that are circulating. And so with this conference, we asked the question to the clinicians, is a clinical definition of AMR required? Well, given a pathology definition for AMR, the conference participants felt that no clinical definition was necessary. Specifically, cardiac dysfunction was not mandated to define AMR due to emerging evidence that asymptomatic AMR is associated with subsequent development of CAV and mortality. CAV is cardiac allograft vasculopathy, or that are atherosclerotic vasculopathy that you see not only in heart but in all organ transplants. Donor-specific antibody was also not mandated, as these antibodies are not always detected. In some studies, it's only seen in about 30%, 50%, maybe as high as 60, 70% of rejection, depending on who you read, but it's not there all the time. And of course, this may represent non-HLA antibodies, or maybe all the antibodies are absorbed onto the graft. Well, that's what Dr. Tarasak used to tell me all the time. You're not looking in the right place for the antibodies. I said, okay, good idea, Paul. Of course, I believed everything he told me, so that's pretty good. All right. And so this is the data we had for asymptomatic AMR. This is from my group. 246 patients between 97 and 01 were divided into three groups. Treated asymptomatic AMR, untreated asymptomatic AMR, and no AMR, meaning the control. And basically, when you looked at 5-year outcome, it was the same in terms of survival, but 5-year freedom from cardiac allograft vasculopathy was significantly lower in the treated AMR and the asymptomatic AMR groups compared to that of the control group. And this is what it looked like in terms of the Kaplan-Meier curves. In green represents the control group in terms of freedom from, so the higher the curves, the better. And then you can see the red curve here is asymptomatic antibody-mediated rejection. In beige is the symptomatic antibody-mediated rejection, and freedom from cardiac allograft vasculopathy is much lower in that cohort. And so this was also seen in the Utah group as well. And so we now realize that you can have asymptomatic antibody-mediated rejection with consequences. And in fact, in the Utah group, they showed increased mortality in that cohort of patients as well. And then move forward now to the STAR group, Sensitization and Transplantation, Assessment of Risk. You heard a lot about that this morning from Anat Tambor and Patricia Campbell. And I was part of this group as well, and it was striking. We really did get down into the weeds in terms of really looking at all of the literature in terms of supporting what naive and memory patients are all about. And we look at that too. Even now, we look at our memory patients with a little bit more risk, and we know that they are higher risk type patients, and we've been able to isolate that as well. And this was a collaborative effort between the American Society of Histocompatibility and Immunogenetics and the American Society of Transplantation. And you can see the goals were to perform a critical review of the literature per se with donor-specific antibodies. And the results of the sensitization and the STAR meetings were summarized and providing the recommendations for the definition and utilization of HLA diagnostic testing. Now, you heard that there was a 2017, 2019, just last week at the CEOP meetings, and there'll be another one next year. So this is a continuum, and this is where we are in transplantation today in terms of what these antibodies actually mean. So it's good to know that there is continuous effort within the community to truly define antibodies and to know whether or not they're deleterious and how to define this cohort of patients that perhaps would be benefit from therapy. Now, there are some novel diagnostic assays to detect antibody-mediated rejection. I can tell you in heart transplantation, we have a gold standard, which is the endomyocardial biopsy. But the biopsy is invasive, painful, resource intense, and therefore there's an unmet need for a non-invasive way to detect rejection. But again, when we look at rejection per se on the biopsy, we have a problem with concordance of reads, and the reads are not always the same. We took three expert pathologists, and we showed them the same slides. This is from the Cargo 2 trial. And in only 2/3 of the cases was there concordance of myocyte necrosis, meaning rejection that needed to be treated. And in fact, in one study, the Cargo 2 trial, there was only a 28% concordance rate with that 3A rejection. So there is an intrinsic problem with the current pathology approach to diagnosis rejection in heart transplantation. The lesion definition of lesions is based on expert consensus and not on clinical outcomes. Grading is modeled on morphologic features and not on functional or pathologic evaluations. And we may see lymphocytes in the endomyocardial biopsy, but we do not know if they are exerting a cytotoxic activity. Traditional histologic methods are often subjective, and concordance, as I mentioned, was as low as 28% for cardiac 2R rejection, which is, again, myocyte necrosis. And why is that? That's because there's a lot of artifact that we see. We can see an old biopsy site. The biotome tends to go down the same pathways, so we end up biopsying repeated same area. And you have a lot of repair. And if it's early after transplant, you'll see a lot of inflammatory cells. Infection, cytomegalovirus, toxoplasmosis can show you some infiltration of cells as well. And the quilty effect. This is seen in the cyclosporin era mostly, now in the tacrolimus era. And this is a subendocardial accumulation of lymphocytes. We feel it's benign. It's not been correlated to rejection, but they have finger-like extensions into the myocardium. So when you take oblique cuts, you can actually see this myocyte necrosis in the center of your biopsy specimen. That turns out not to be rejection, but it is confused by others in terms of whether or not that truly is rejection, yes or no. And so is there something that we can look at in terms of the endomyocardial biopsy itself? Maybe, and this is called intragraft mRNA assessment of rejection. This is molecular phenotyping, which offers a possibility for increased accuracy in diagnosing and treating pathologic states. Traditional histological methods are often subjective, and the results are qualitative, as I've mentioned. By relating gene expression to disease states, a system can be created to diagnose pathologies. Now, Phil Halloran at the University of Alberta has devised such a system for identifying rejection and allograft injury in transplant biopsy samples, and you probably know about it in terms of the molecular microscope. It's a diagnostic system. Now, how does it work? Microarrays analyze the mRNA in biopsy samples suspended in a RNA reagent, RNA lather. Machine learning builds algorithms that assign probability of a disease state known as classifiers. And I'll get into the classifier issue. Now, a classifier algorithm uses multiple gene expression values in contrast to traditional simple gene sets. So these transcripts. They're called RATs, rejection-associated transcripts. And they are transcripts that tell you, basically give you pathways of natural killer cell pathway, endothelial cell pathways, T cell activation pathways. And the new biopsy results are compared to 15 nearest neighbors in a reference set. And they use this archetype analysis, and I'll get into that. And when we talk about the RATs, the rejection-associated transcripts, you can see there's T-cell-mediated landscape, there's an antibody-mediated landscape. As you can see, it's some overlapping, meaning natural killer cells are seen in both of these landscapes. But basically, they are individual, and you can see basically whether or not there's T-cell-mediated rejection or antibody-mediated rejection that's actually ongoing into the graph. So for the first time, maybe, we can see what the mechanisms are that are ongoing, what's being activated. It's not perfect yet, and I'll get right into that as well. And this is the archetype analysis. It estimates the probability of no rejection, T-cell-mediated rejection, antibody-mediated rejection in a single endomyocardial bite. Archetype analysis is an unsupervised method that assigns each biopsy a score based on its similarity to cases in the reference set, scores that add up to 1.0. Basically, it'll give you a percentage that, yes, there's an 80% chance that this biopsy represents antibody-mediated rejection. Now, Phil looked at both kidney transplants, heart transplants, lung transplants to see what type of analysis you would come up with, and would they be similar amongst all three groups? And the answer is, yeah, they were quite similar. In red represents no rejection, in blue dots represents T-cell-mediated rejection, and the green dots represent antibody-mediated rejection. And you can see through these principal cohort analysis that it's basically very similar, whether you look at kidney, and there's 1,200 samples there, in heart, 331 samples, in lung, 58 samples. That's why you see such few dots there as well. But then the idea is very similar. Now, recently, working with Phil and our group, there were only a few of us that are involved in this study in the United States, but several others in Europe as well. Phil's been able to find another transcript set, and that's similar to, or that's now called chronic injury. And we see this. We see this in heart transplantation where the ejection fraction is down to 35–40% for the last 5 months. And we think that there's rejection ongoing, or you might do some other endomyocardial biopsy, but we don't see very much. And when we use the mRNA transcripts, what we saw was nothing, no activity. And we realized that sometimes these rejections get burned out, and you're left with just injury and scar. And when you look at MRI, MRI will confirm that there's fibrosis, ongoing diffuse fibrosis. In other words, it's either burnt out rejection or it's small vessel transplant vasculopathy, and we have seen that on explanted hearts as well when they undergo retransplantation. So this is what we see. Now, we've done the study called the InterHeart study. This is a prospective validation of the molecular microscope in heart transplantation. We assign molecular scores, again, probability, which adds up to 1.0, of T-cell-mediated rejection, antibody-mediated rejection, in the transplant biopsies against a reference set of 200 biopsies. And we created classifiers that predict antibody-mediated rejection and T-cell-mediated rejection. And this is what it actually looks like. The sets are standard in the background. We take our patient sample and we basically can place it on that background to see where we are. What is that biopsy sample telling us? In the picture to your left, you can see our sample is right here in this triangle with a circle. And that tells us, you can't see it from the back, but an 82% chance that this is indeed antibody-mediated rejection. And so the first time now we're actually being at least believe that maybe there's something going on in a biopsy that maybe doesn't show us very much. And if your biopsy sample is out here, and this is the T-cell-mediated rejection area here it's a 100% chance that this is indeed T-cell-mediated rejection. Well, so we've been doing correlations with pathology and finding that there is a very good, excellent correlation when the pathologist says that there's some rejection, but then we started, as we did more and more samples, we started to see some other findings. And then working with the Italians, with Luciano Potenna, we were able to look at the samples. And this is what we found, which was very surprising. All right. In this figure here to your left, this is abnormal pathologists that are calling rejection. But when they called rejection, we looked at the abnormal molecular profile. And what we saw is that only in 58% of those cases did the molecular profile say, yes, this is rejection, in terms of what the pathologist was calling. And then when the pathologist called a normal pathology, meaning no rejection, in 12% of cases, we saw activity in the molecular microscope. Well, we looked at this, and you know what this represented? This represented biopsy-negative rejection. That's when we see an acute decrease in the ejection fraction. 2 weeks ago it was 60%. Now it's down to 40%. And when we sent those off, we found this, that indeed it represented rejection. And pathology shows no rejection, or maybe 1R, which is mild, which really doesn't mean very much. And then we looked at, of this 58%, what does it represent? Most of it represents in red antibody-mediated rejection, T-cell-mediated rejection, or mixed rejection. And this is, again, no rejection in 42% of cases. And in the biopsy-negative type rejection, you'll see most of that is antibody-mediated rejection. Not to say that this is now the holy grail, that this is the gold standard. There's a lot more studies that need to be done on this, but suggestive that maybe if we look at the graft itself, we can see what's going on inside, what mechanisms are being activated, and what truly represents rejection or not. And I see this as an adjunct to the endomyocardial biopsy read. Use them together. Let's see if we can refine what rejection is all about, and maybe have a better understanding of what rejection is all about as well. So stay tuned, more to follow on this, and I think it's a very exciting way to pursue this as well. Well, we also looked at the evidence for donor-specific antibody, and interestingly, with rejection, you can see with the molecular profiling, it detected basically almost all that was positive for DSA, about 30% of patients having DSA, and they had rejection in those situations. In pathology read, of course, they're not going to know what's positive or not, so you can see it's pretty much the same on both sides. So again, some interesting findings that antibodies are being indirectly detected in the graft itself with the antibodies that are present. So again, more to follow on that as well. Now, I'm going to end with treatment of circulating antibodies. You heard a lot about that this morning in terms of desensitization therapies. And I won't go over the same ones that they talked about this morning, but we'll talk about some of the ones we've done in heart transplantation. And Dr. Terasaki asked that question back in 2003. If the humoral theory is accepted, even provisionally, transplanted patients who have antibodies could be treated with immunosuppression until the antibodies disappear to determine whether chronic rejection can be blocked. Interesting concept. Is it true? I don't know yet. I think we have a lot more to treat and to basically see what works and what does not work in our patients. Now, this is the treatment of circulating antibodies, the current concepts that we have, and you can see that there are many. Elimination of circulating antibodies with plasmapheresis, inhibition of residual antibodies with IVIG, suppression or depletion of B cells, rituximab, and now obinutuzumab, which is a humanized form of rituximab. It is actually more powerful than rituximab. What I understand, it's cheaper. We'll see. Suppression of plasma cells with bortezomib, carfilzomib, and binding of complement with eculizumab. And of course, I didn't put down itis here that we heard a lot about this morning. Very exciting therapy, potentially for many of our patients as well. Well, this is desensitization. I just put this table up. A lot of that has been discussed with tocilizumab, C1 inhibitor. And we use C1 esterase inhibitor, and I know my colleague Stan Jordan at Cedars has done work with that as well, and then itis that you see right here as well. I just show you this and what we do at Cedars-Sinai in terms of our protocols. We have two protocols, one for outpatients where we have time to treat our patients, and then with our urgent patients, we have another protocol that we use. Again, just an example of what we do, and again, a lot of this was taken from our colleagues in kidney transplantation. We use IVIG rituximab desensitization protocol, high-dose IVIG, 1 gram per kilogram daily times 2 days, and then we give rituximab in 1 week, and we check PRAs at that point in time. Have we been successful? Yes, in most cases we are. We can actually knock down antibodies from 75% down to about 35%. This is a calculated PRA. And this patient cohort, again, it doesn't work in everybody, and particularly as we get higher and higher in terms of the highly sensitized patients. What about those patients that are hospitalized? We use bortezomib, 1.3 mg per meter squared with plasmapheresis on these days here. And here's actually a schematic of what we do. Plasmapheresis Monday, Tuesday. We give bortezomib after plasmapheresis on Tuesday. Rest day on Wednesday, Thursday, Friday. We do the same thing. Weekends, we don't do anything. The following week, we do the same protocol. So basically, it's a 10, 11-day protocol. And have we been successful? Usually, we use this for patients who are refractory and small cohort of patients, but these were all refractory to rituximab IVIG, and we're able to knock down their CPRA as well. But again, the highly sensitized are problematic. Now, what about those highly sensitized patients? Now we know we can use IDIS, but I think we still have to figure out how to treat these patients afterwards. So, we cannot tolerate any type of severe rejection in heart transplantation. Patients would die, and they have hemodynamic collapse. And so, basically, we've gone to a drug, eculizumab, which is a complement binder. And we didn't really talk about a lot of that this morning. But this is a humanized monoclonal antibody that binds to and subsequently prevents activation of the complement component. Basically, eculizumab will block C5a into C5b, the anaphylactic toxin, and prevent the membrane attack complex C5b, 6, 7, 8, 9. And that you need to have or should have in terms of causing destruction to the donor cells itself. And so we started a protocol called the DUET trial, de novo use of eculizumab in highly sensitized patients undergoing cardiac transplantation. This is a pilot study using eculizumab immediately after heart transplant for the highly sensitized CPRA of 83%. And several of these were 99%ers as well. In order to get into the study, we have to cross DSA, and some of the DSA we crossed were high MFIs. Yeah, I know MFIs are not always the story, but it tells you an idea that they were high, and even with one-day dilution, they were still high. And we do one-day dilution routinely in all of our patients, highly sensitized patients as well. And this is the protocol that we use, day 0, 1,200 milligrams. You can see we gave it basically for 2 months, after transplantation. We also gave thymoglobulin for 5 days, followed by IVIG, along with the eculizumab. And it was we looked at the prospective donor-specific cross-match, and we did mandate that the CDC cross-match was negative. We weren't really feeling that we could go against a positive CDC cross-match, but realizing that we were crossing very high levels of donor-specific antibodies as well. So, and the cross-matches, although they're there, don't tell us the whole story as well. We've had some retrospective cross-matches that were, have been positive as well. So it does create a bit of angst on our part as well. But these were the preliminary results. We've now done 20. In July, we'll have 1-year follow-up for everybody, all 20 of them. But for now, we have a 92% 1-year survival. What is it in heart transplantation? 90%. So we're pretty much right there. 1-year freedom from cellular rejection. Nobody had cellular rejection so far. 1-year freedom from antibody-mediated rejection. 76%. Not bad at all. 6-month left ventricular ejection fraction. Normal. Everybody had normal function. And patients with DSA at 1 month, it was 100%. By 1 month, we're down to 71%. Actually, in the ones that we're looking at right now, most of them have literally minimal donor-specific antibody that are there. 1-year freedom from any treated infection, 58%. It's about 50% in our group. Of course, we have a lot of patients with driveline infections going into transplantation as well. But it's quite striking that this was a group that we view as high risk. Now, do we have a control group? No, we don't. But working with Alexander Lupi from Paris, he has the now cardiac eye box as well. And so he's found a comparator group, very similar to our group, with high levels of DSA. And when we compare the two groups, what do we find? We have far less AMR than his control group. Now again, it's a match control type group, if you will, but certainly it's indicative that maybe we're doing something here. Maybe there's some feedback here, mechanism whereby the eculizumab is helping to knock down the antibody response as well. So we're doing mechanistic studies. We'll see what we find as well when we analyze the entire group and have everyone complete that 1-year mark. And let me end now with IL-6 and the inflammation post-transplant. With IL-6, interleukin-6, it's truly a pivotal type of cytokine that we see. It has a lot of pathways that it activates. In fact, one of the big ones that it will activate is antibody production that we see here, and the inflammatory markers, hepatocytes, differentiation of various cells of megakaryocytes, synovial fibroblasts, myeloma cells, mesangial cells, proliferation of keratinocytes. So we certainly believe that certainly if you look at interleukin-6 blockade, you might be able to see something. And so in the literature, when we looked at it, you can see IL-6 inhibits coronary artery vasculopathy in humanized mouse models. And no treatment here, and you can see far less intimal thickening here in this artery. And endothelial cell interleukin-6 production is markedly decreased when you use a blockade. And the blockade is basically tocilizumab or clazakizumab, which is now available as well. And so Stan, my colleague Stan Jordan, has done a nice study looking at tocilizumab, and it was presented this morning too. I won't really go over too much in detail, but basically they were able to knock down antibodies here as well. And so what have we done in heart transplantation? Well, we put together a study, and we don't have the results yet, so I don't have studies to talk to you about. But this is currently a prospective NIH-sponsored, multi-center randomized blinded controlled clinical trial. 200 heart transplant patients will be randomized 1-to-1 to receive either placebo plus standard triple immunosuppression or tocilizumab plus standard immunosuppression. Composite primary endpoint will be death retransplant, hemodynamic compromise, incidence of acute cellular rejection, antibody immune rejection, and the development of de novo donor-specific antibodies. We have concurrent mechanistic studies to assess the effect of tocilizumab on interleukin-6 in vivo inflammatory cytokine profiling, T-cell effectors, and regulatory cells, antibody production, allograft fibrosis. This is Peter Heger's lab that's doing this. Jordan Mattson is the PI, and I'm the protocol chair, basically putting together the clinical trial. So we've already started enrolling. So hopefully we'll have completion of enrolling in the next 2, maybe 2.5 years at this point in time, and we'll follow them up for at least 2 years. We'll see if we have a change, and we're using intravascular ultrasound, so we'll take a look at the intimal thickening in the first year. I think I'm really excited about this. One of the first clinical trials to really look at a drug that may actually decrease antibody production if we believe the mouse studies that we've seen, and maybe some of the preliminary kidney studies as well. So in summary, Paul Terasaki promoted the humoral theory of transplantation and contributed greatly to the identification of antibodies. And over the past 50 years, the detection and identification of circulating antibodies have progressed and have been shown to impact outcome in both pre- and post-transplant patients. The intrograph mRNA transcripts may pave the way to improve our detection and understanding of the pathology of rejection. Still preliminary, though. We'll still have to wait and see if it truly does work that way. And there are promising drugs currently in study that may be more effective in the approach and management of sensitized patients before and after solid organ transplantation. So in memory of Dr. Paul Terasaki, I bid you farewell from sunny Southern California. Thank you so much. I'll take any questions at this point. Adriana gets up.
I have to because, first of all, it's a wonderful journey. And I want to share with the group here that I remember when the meeting of ISHLT was in Osaka, in Japan. You were in the program committee and you demanded to have some HLA component. And I thank you for that because we were there. And you know, it takes the leadership of a certain society like ISHLT to embrace the discipline that we were bringing to the table, and you did that. You did that early. We had many fights. I think I left the room many times. I also danced.
Yes, I remember that. You were a wicked dancer as well.
That's right, in Japan. But what I want to say that it's very important, and it's true that I was on the board of ISHLT. We had that passion to learn and to look for, and I think there's still a lot of discussion. I can say a few things about what you presented that I would add to it, but that's not important. What is important is the fact that we need that kind of interaction between the clinician, the laboratory, the discipline, the multidiscipline approach, because without that, we don't make progress. And I think Dr. Terasaki was bringing that to the table, and I'm happy to be part of that history and embrace that. And what we need to do as a group is to educate the newcomers, the clinicians and the fellows and the leadership, because without that interaction, we cannot bring it to the clinic.
Thank you so much for those comments, Andrea. Very, very important. Any other questions? You're all shy. Well, yes, please.
Thank you for a wonderful talk. The study you're doing with Ectozumab, are they selected as VAD patients or non-VAD or no?
So the question has to do with VAD patients and about antibodies in VAD patients. You mean in terms of our duet trial? Yes. I don't know how many. Again, it's a small number of patients. The VAD patients are very interesting, to say the least, because when you take the VAD out, the antibodies tend to drop. Not in all VAD patients, because some have some congenital heart disease. They have autologous type of conduits that are put in, in terms of humanized conduits. And so they're somewhat different. But it's interesting that we've been able to demonstrate that when you take the VAD out, there's something that's going on in the system. It's like some stimulator that you're taking out. That may be a great group of patients for itis, actually. Why? Because if you take the VAD out, itis is on board to take down the antibodies. And why is that an important point? It's an important point because right now, about 50% of all transplants are being done on VAD patients. And with the new allocation scheme too, patients on mechanical circulatory support do have higher urgency status and they're getting transplanted. And so and that's why the number of patients with sensitization has increased quite dramatically over the course in time. And we're going to see more issues with antibodies. So yeah, it's a good question, and we'll see what happens to these patients.
John, so the molecular profiling, so in the rejection group, the 58% of the patients showing subsignatures, antibody-mediated rejection or cell-mediated rejection signature, but 42% you don't have any signature. So do you think you can apply other systems and see more sensitivities, or how can you shed some light on that?
So, some of you may not heard that. Can we confirm that 42% of the interheart study, meaning intragraft mRNA transcripts, that 42% are truly quiescent or not? Yes, we actually did. Our center, we also are involved in cell-free DNA. So we looked at our cell-free DNA group, and that's a different biomarker, if you will, for rejection. When you see donor-derived cell-free DNA rise, that suggests that something's going on in the donor and suggests that there is rejection. So we looked at donor-derived cell-free DNA, we looked at intragraft interheart, and then we compared all of that to the pathology read. And both interheart and cell-free DNA had about a 75%, in our study, a 75% concordance with pathology. So about a 25, 30% discordant rate, a little bit less than the 42%. But when we compared donor-derived cell-free DNA to interheart, it was 100%. I don't know. I mean, still small numbers, but suggestive that looking at it from many different angles, that we're seeing something that was concordant, that consistent with what we're finding. We need a lot more data than that, but you asked the question, so I'll give you an answer as well.